There is a paper that has come out in the past week looking at the association between COVID vaccination and sudden death. And this has been doing the rounds because largely it's giving the population reassurance. There doesn't seem to be a link. But there's a reason why I like these papers because they oftentimes give us an important indicator that, if not careful, we have to look and dissect to understand what is going on. Because when a paper like this comes and it shows that there is no significant association, and this was a paper that was done in Toronto, produced in 2026, and they looked at cardiac arrest. This was the conclusion. These findings do not support the hypothesis that COVID-19 vaccines increase the risk of sudden cardiac deaths in young, healthy adults. And this is specifically what it looked at. But there is something very important in this paper that I think needs to be dissected. I have always found that the arguments are too superficial. Some people say COVID is the cause of everything, the infection. Then another cohort says COVID vaccination is the cause of everything. And this is what this paper is trying to answer. But I'm more nuanced. I'm looking for something else. And this is what I want to show you about in the next few minutes. And so what we have here, and I'm going to show you the picture, is what I call the COVID storm. This is what it looks like. So in this situation, what you have is a pathogen that is continuously infecting people, and you have a proportion of the population that has been immune primed. Now, this can also occur from infection, but primarily I suspect the priming would occur from vaccination. When you put the two together, you get a different presentation of disease. And this is what I have been talking about now for years, because based on the trajectory, I would suspect that this is our big issue. So when a paper like this comes out, and just in case you're just joining me, the conclusion of the paper is that these findings do not support the hypothesis that COVID vaccines increase the risk of sudden cardiac death. But in reality, it's saying something even more significant than that. And when you look at the images in terms of the data, it's almost suggesting that COVID vaccines are protective against sudden death. Now, this is very unusual. And if you look carefully at this image here from the paper, this is in figure 2, looking at the odds ratio of death and COVID vaccination among the matched cohort. And what you're able to see here is that one represents the, I guess you could say, the neutral position. Anything to the left of one means protection. Anything to the right means that there is higher risk, okay? And what you're seeing here is that the lowest risk cohort is 0.53, which is at least 2 doses of COVID vaccination. mRNA, slightly higher, which makes sense because it can cause myocarditis. Any COVID vaccination, 0.57. 0.63, any COVID vaccination within 6 weeks of death. Remember, all of these are showing protection. And 0.88, single dose of COVID vaccination. I'm going to come back to this shortly because this is also one of those really important points. Now, when it comes to these things here, I sometimes ask myself very simple questions to try and clarify what is going on in my mind. And so, if you were to tell me that not COVID vaccine, smoking, let's pick smoking. This is what I was thinking about today. If you were to tell me that smoking was protective against lung cancer, and you produced a study that showed that, my response would not be, oh my goodness, wow, smoking is protective. Everybody should therefore be smoking. No, no, no. I would say, hold on. you would need to explain to me how it is possible that something that damages the lungs, damages the vascular system, could be protective against cardiovascular or lung pathology. It would make no sense. And I would go back to the data to say there must be something wrong with the way that you approach the data. And there were studies like that in the 1950s when they were questioning about smoking. The tobacco lobby was very powerful, and they kept on putting doubt in the population. It lasted for almost 30 years, 30 to 40 years, before finally they had to acknowledge, okay, this does cause risk. I suspect we're in a similar kind of timeline. And so, what you have to realize is that when you look at the patterns that are occurring across the population, you will realize why I think this is so important. Some people think that this is just about trying to get at the pro vax or the anti vax, or that for me, that is irrelevant. What we need to focus on is actually what are the risks to the population. And when I did this analysis, and when I show you this picture, I just did a presentation on this. If you want to watch it, the link is in the description below about the cardiovascular crisis. This is serious stuff. This was looking at 186 million hospital episodes in the UK. And when you see this kind of pattern across multiple ICD codes, 50% up for cerebral artery occlusion, 189% up. This is since 2020, 2021, and rising. Hypertensive heart and renal disease, myocarditis up 50%, pulmonary embolism up but flattened, heart failure up, atrial fibrillation and flutter up. All of these heart-related patterns have been increasing since the pandemic. The question is why? What is going on? And this is what I mean, is that for me, my expectation would have been, and this is just my thought, if you are looking or say cardiac arrest or something like that, the best you should observe is that there is only a very slight increase above normal. You cannot tell me that when we know that the pathology indicates that there is myocarditis, there is changes with the way how the heart uses glucose and fats up to 180 days after vaccination. You cannot explain to me pathophysiologically how that can be protective to the heart. I can acknowledge that, okay, maybe the risk is really tiny. But from my perspective, and this is important for you to understand, this is my view. If you show me protection, I think there is something wrong with your data. Okay, that's my approach to it. And so when we looked carefully at this study, and I'm going to take you back to a few points in terms of what they did. So this was a young cohort that they were looking at. When you see here, this was in Ontario, Toronto, Canada, case control study, ages 12 to 50. They took out people without documented comorbidities. Now, I think they should have done two layers of studies, is that they should have looked at the people without comorbidities and the people with comorbidities to try and understand what implications that happens. I think they were just trying to prove that the vaccines were safe. So they were looking at predisposition to premature death between the 1st of April 2021 and June 30th, 2023, looking at COVID vaccination and sudden death. And the primary outcome was sudden death. Now, so this is important because we've wanted them to do this kind of study for a long time. And so the exposure of interest was any COVID vaccination. So they were looking at 6 million people, of which 4,806 cases experienced sudden death, and they matched it to 24,030 controls who were alive. And so they were looking to see, is there any difference between the ones who died and the ones who were alive in relation to COVID vaccination? And as they said, COVID vaccination was not associated with increased odds of sudden death. So this then makes it appear that, okay, the question is over. No, I don't think so at all. I think that's just a starting point. And to be frank, I would love to get the raw data. I'd love to be able to give it to AI and say, I want you to analyze it, looking for specific things, because there's two important flags that I'm going to highlight from this paper that I believe should be investigated far more seriously than it has been. And as I said, in case you just missed, this is not about whether or not we prove that the vaccines are a problem. This is about the fact that we have a problem. All of these cardiovascular related conditions are rising at a rapid rate for which we don't know the mechanism. And for us to pretend that this cannot be a factor, in my view, is very, very lazy science. And it is not in the interest of anyone, whether or not they're in healthcare or they have part of the ideology. It is not in anyone's interest to ignore these patterns. We have got to understand what is going on. And as just a reminder, in case you've just reached, my view is that this is indicative of a COVID storm. You would have heard me talking about this for many, many times, and this is what it would look like. You have a population that has immune priming. The truth is, some people can have immune priming from the infection. Say they got severe COVID with myocarditis in the early part of the pandemic. Then you have another cohort of that who had immune priming from vaccination. My view is that if they had cardiac related symptoms post vaccination, shortness of breath, palpitations, limited exercise tolerance, chest pain, unusual patterns, that in my mind would suggest immune priming. The question then occurs, what happens when they get infected again? Does the immune system respond in the same way, or does it cause what I call a COVID storm, spike triggered autoimmune response mechanism? This can lead to multiple presentation of pathology. So this is what I have been looking at, as I said, for a long time. It's not new. And there is something in this paper that, in my mind, points to a very important signal. So when we look at the details, I'm now going to get you of the first bit that I want to highlight that I think is very, very important. When we look at the baseline characteristics, and so this is from the paper, baseline characteristics of the people, it looks at their ages, looking at cases versus controls, all the way 12 to 18 up to 50 years. So this is a younger cohort who shouldn't have comorbidities, and they took out the comorbidities for these cases. Looked at the different regions. They looked at the neighborhood income quintile, the lowest. You can see here, and you have to remember cases and the controls. The cases are 4,806, controls are 24,000. So when I look across, you can see here that of that 4,000, 12,091 were in the lowest quartile, 26.9. It matches the control. You can see there again, cases and controls who are still alive. And you can see here, even in the highest income, it matches 727 out of 4,806, 15%, 15% of the controls. Perfect. Good. As we roll down here and we move to the other part, this is where it starts to get interesting. So as you have the cases and the controls again, I have highlighted here this bit, which I'm going to come back to, number of COVID vaccines received. So if they had no vaccines, the cases, 32.6% were higher who had cardiac arrest compared to 22.9% of controls. So this is part of the reason why it appears that having vaccination is protective. If they had one vaccine, you can see here 6.8%, 325 cases, versus 5.9%, 1,423. And so you can see here again that this is still slightly higher than the controls. Where we see the big difference is greater than 2, 60% versus 71% of the controls. So this is where it appears the protection lies. Now, we're going to come back to this in just a minute, because this is an important factor with regards to single dose. Here is the bit that I think is very important, and it ties in with my COVID storm. When we look at recent COVID PCR test before test date, never tested positive, 91% in the cases, 92% in the controls. That's fine. Remote prior positive test, meaning greater than 90 days, 6.1, 7%. No significant difference. But here we have recent positive prior test, less than 90 days, 2.2% compared to 0.9%. This is fitting exactly where I'm predicting that we have a COVID storm. This is why I said I prefer to have the data rather than just simply the outcome from the authors. Because just to remind you, let me keep you on track here. What I said, I suspect, and this is from my research, from my analysis, there is a cohort of the population who have had some degree of cardiac damage after vaccination or even after severe infection. The concern is what happens if they get a further infection? Do the areas in the heart that have been damaged and are inflamed, do they get worse inflammation and trigger unusual pathology? Like they may get chest symptoms, shortness of breath, chest pain, palpitations. That indicates to me that this is the cohort that is at higher risk of a COVID heart storm. They have been immune primed. They have a recent infection. They have unusual pathology occurring in their heart. And this represents to me the COVID storm. And as I said to you before, it does seem, and what we would want to be able to understand and what should be done with this kind of research is that when you look at this cohort here with a recent positive test, I would have wanted the authors to tell us of these 107 people who died, what percentage of them were vaccinated and how many doses. This to me is a critical part of where the answer is. And this is why I said that this is only the start of the process. The second part of what I've been highlighting is the issue with regards to heart damage, okay? I'm going to show you two images, and these are now me doing my presentation on it. I'm just seeing if I can get to the picture that I want. Okay, yeah, I've got it here. So I've taken the image from the paper and I have put it on a separate thing so that I can adjust it. And this is what I have here. Adjusted odds ratio, 95% confidence interval for death and COVID-19 vaccination. Anything to the left of this line represents protection. Anything to the right usually suggests greater harm. And so we can see that in every cohort, there seems to be a protective effect. It's strongest with at least 2 doses of COVID vaccination. However, here's the problem. Why is it different for those who only had a single dose? 0.88 versus 0.53. So even if you said this was protective, why was it less protective for those who had a single dose of the COVID vaccination. Now, this is an important point. Again, what I'm saying is I believe that the cohorts who are vulnerable are people who had abnormal symptoms. This is where I think that we need to go, because there are a lot of people who still have ongoing symptoms who need to be helped. And the system is just ignoring them because it's just saying, well, we haven't found any problem. So if you've got symptoms, yeah, so you got your symptoms after you are vaccinated. So what? It doesn't mean there's a problem. And so because there's no acknowledgement of this issue, it is being swept under the carpet. I think that is extremely dangerous. We need to understand what has happened. Now, as I said before, if you told me that there was a study that came out from the tobacco lobby that said that smoking was protective against cardiovascular disease, I would say there's something wrong with the interpretation of the data, because you would have to explain to me how smoking could protect against heart disease. Now, it can make some protection against ulcerative colitis. That's different. But in terms of lung disease, lung cancer, heart disease, cardiovascular disease, increased risk. So if anybody brought a study like that now, I wouldn't go and say, wow, all these years I thought I got it wrong. No, I would go, something isn't right here. We need to look carefully at it. So, in the same way, with what I've told you, if you tell me that every single vaccination cohort has protection against sudden cardiac death, that doesn't make much sense to me. And I go, not too sure. We need to look at this in some detail. But whichever way you take it, these guys are not as protected if they had a single dose. That should be investigated as well. So here is me now doing what I thought should have been done in the context of this paper. So this is now my adjustment. Again, you have to apologize. I apologize for doing my adjustment here, but this is me now taking the data from the paper and putting on top of it my own perspective of what is happening here. So this is what it would look like. If I adjusted it, my argument is there should be no extra protection with any dose of COVID vaccination, okay? So I said that if 0.49 is the lowest interval, then that's where I'm putting my line. The best you can hope for is that the risk is tiny, like here. So I've given that, at least 2 doses, the risk is tiny. But if I adjust this line back to here, suddenly we start to see a huge difference in terms of outcomes, especially here. This would become 1.76. That means if you had 1,000 people, 76 more people would be at risk of sudden cardiac death. That, for me, is the red flag. Now, as I said, many people will argue that they're glad that this paper has shown that all of the stuff going on in social media, all the people talking about people who have died suddenly, and, they're just making it up. They are just looking for it, and this is why they're seeing these patterns. And this kind of paper seems to corroborate what they are thinking, because, as I said, when you look back to the conclusion very clearly states that they have not found anything that supports the hypothesis that COVID vaccines increase the risk of sudden cardiac death in young, healthy adults. As I said, they should also look at the less healthy adults. Is there any risk in them as well? But this is what we're facing at the moment. And I did a piece of thought exercise looking at what happened with tobacco, because I found tobacco as an interesting historical parallel, and the approach that happened with regards to tobacco. I'm going to read out to you some of the points that I came across in the investigation, um, and the tactics that were used at that point in the 1950s and 60s. And what they did, because at that time there was an issue with regards to people saying that there was more heart disease and so on, and this was what was going on, and it was linked to tobacco smoking. So what they did is, first, they then, I'll just read some of these points out to you. They started off amplifying uncertainty. So their approach was to say that more research was needed, but they selected anything that weakened the association between smoking and any other diseases. They were then able to do that for quite a long time, because you have to remember that this was going on for maybe 30 or 40 years, and it was so powerful that very few people were able to break through it in terms of understanding what was going on. So again, the first thing that they did was they manufactured uncertainty. Their aim was not to prove safety, but to prevent consensus. More research is needed. Two, they then created a parallel scientific infrastructure. They had the Tobacco Industry Research Committee, which was funded to look at studies that muddied the waters. Then they undermined key scientific findings. They then used the media to manipulate, leveraging journalism that would go back to both sides reporting and giving false balance. Then the tobacco industry did political lobbying, and they delayed the regulators from doing the kinds of studies that should have been done. Then this one was critical. Their legal strategy demanded impossible proof. They said that you had to demonstrate that this particular brand of tobacco was causing this type of disease. And then they used the psychological framing, with the Marlboro style, masculine, strong smokes. They promoted doctors smoking to show that this was therefore healthy. And they used internal knowledge and political position that showed early awareness of harm. They pushed it back. That was what happened. And it worked for 30 to 40 years with the tobacco industry. Are we facing a similar thing now? Because at the end of the day, and as I said, at the end of the day, you have to realize that I'm trying to think who benefits from us not getting clarity on exactly what is going on. I can understand industry because it may come with liability and nobody wants to pay. I can understand the politicians in the sense that it may also come with some degree of damage to a reputation. But when I think about, say, public health, again, it will damage reputation. So maybe they don't want to face that at this point. I can see that. But when it comes to clinical healthcare community, there is an anxiety that this is real. And so I can understand that because it has personal implications for people. But healthcare doesn't have the luxury of ignoring these things. And as I said, I come back to the basics. When you see this happening across multiple fronts since 2020, how can we ignore it? And as I said before, this in my mind has never been about just, say, the vaccine causing harm. because my view was that you would see it almost immediately. And some people do have that, but that is not the standard. What I think is the standard and what I'm looking for from a research point of view is the storm. Immune priming, recurring infection, which is still happening in the population. The two are like epoxy. One or the other doesn't actually cause anything to happen, but when you put them together, you get this COVID storm. This was done by Gemini, a great image here. But this storm couldn't have done it better. It's no longer presenting in the same way. This is now like a new disease. And this is where we are at. The challenge is, therefore, what do you do about it? Because many of you are lay audience. I'm not talking to public health at the moment. And what I'm going to be doing is taking the data from the hospital admission episodes and trying to put it in front of people who are responsible for population health. Because I don't see how anyone can ignore what is happening. We have to find the reason. Even if it is just infection, we at least would know, and then we can prepare the population accordingly. If there is any involvement with immune priming from vaccination, we also need to know, because we would then be able to stratify who is at highest risk. This is the kind of research that needs to be done. And we still have a long way to go because there's still a lot of ideology. Nobody wants to touch this. But my point is, it's not going away. The risks are increasing across the population. At some point, we have to bite the bullet and we have to look carefully and try and understand what is going on. Thank you for staying with me and have a great evening.